Welcome everyone. My name's Lisa McKenzie and I'm the IHI Asia Pacific Regional Director, and today I have the pleasure of facilitating this session. We're so pleased that you're joining us to be able to discuss the essential elements for achieving improvements. We've got a really fabulous panel who are going to be sharing their insights and the lessons they learnt from 3 Australian maternity collaboratives. Before we dive into the session, I'd like to begin by acknowledging the Wurundjeri people of the Kulin Nation, who are the traditional owners of the land where I'm located. And I want to pay my respects to their elders, both past, present and emerging. And I also want to extend that respect to the Indigenous people who are the traditional owners of the land on wherever you are located. This picture I took on a bit of a walk only a couple of days ago, and I feel really fortunate to live very near this very beautiful spot. It's only a short walk from my home, and it always makes me feel really, really grateful for the continuing care that our Aboriginal and Torres Strait Islander people have devoted to this land. Now, I'd love to start with some introductions to our terrific panel, and we'll start from left to right. We've got Dr. Barb Vernon, who is the CEO of Women's Healthcare Australasia, a non-profit community of more than 140 maternity hospitals. And so Barb will just give a wave there. And Barb was the exec sponsor for the National Perineal Tears Collaborative. And while she doesn't regard herself as a QI expert, she's absolutely brilliant at joining the dots between those with QI expertise and clinicians who have a real passion for improvement. Next, we've got Dr. Deborah Browne, who is the director of the WHA National Collaborative. And this role really leveraged her deep knowledge as a senior medical specialist, a high-risk obstetric anaesthetist, and also a QI expert. And having finished the collaborative, she's now co-authoring an academic paper on this work, and she's also begun a new career as an aspiring novelist. So welcome, Deborah. And then we have Felicity Zanacki, who comes to improvement from a clinical background in nursing and midwifery, and she was Safer Care Victoria's collaborative director for the Safer Babies and Better Births Collaborative. And Felicity has a very real sense of adventure. She's currently trying to convince some of her friends to learn rock climbing. And as soon as we get out of lockdown, I believe that's what she'll be doing. And last but not least, we've got Rebecca Reid, and Rebecca's the director of the Improvement Partner at Safer Care Victoria, and she was also the Improvement Advisor for the Safer Baby and Better Births Collaborative. She's a very avid baker. She's got a very creative flair, and she makes some spectacular creations for her kids' birthdays. And when I say this, I do not mean the kind of baking disasters you see on Nailed It. I see the absolute gorgeous cakes that are also delicious. So welcome, Beck, as well. So huge welcome to the whole panel. You've seen our session overview and the objectives in the program, but our plan for the next hour is to provide a bit of a summary of the improvement approach that was used in these 3 maternity collaboratives. The first being WHA's National Collaborative to reduce perineal tears. And then you can see we had the Safer Babies Collaborative, which was about trying to reduce the rate of stillbirths. And then the Better Births for Women Collaborative, which really built on the successes of the WHA National Perineals Collaborative. And we're going to spend most of the time discussing the lessons learnt and the panel's aha moments and the things that they learnt along the way, not only the things that went well, but also the things that didn't go quite to plan, the sort of fail forwards that they had. And we're also going to be very sure to leave you some time at the end so that we can actually have a bit of a discussion with you. You can ask any questions you might have and also share your own insights. However, if you've got any questions or comments and they come to mind during the session, just pop them in the chat and we'll try and come back to them when we have time at the end. So this session's all about improvement. And so before we kind of dive into the content, we just want to, I guess, recap the 3 critical components that need to be in place just to set yourself up for success. So first, you need will to try and change the status quo and do what it takes to achieve improvement. And then you need ideas. How can you actually make improvements in whatever your local context is? And pleasingly in healthcare, we very, very rarely have a shortage of ideas. And finally, we need a roadmap or some kind of execution model to try and help us test and implement these change ideas to achieve measurable improvement. And we've got this pictured, as you can see, as a sort of 3-legged stool. And if you're lacking in any one of these, so if you're lacking in will or you're lacking in ideas or you're lacking in execution, the stool's going to get a bit wobbly and might fall over, meaning that you're not going to have what you need in place to make improvement. Now, the panellists are going to tell you a little bit more about how they developed will and what their change ideas were. But we thought it was worth stepping through the execution model that all of the collaboratives used. And they used something called IHI's Breakthrough Series Collaborative Model. And it's and I've got some links on this slide, so you're welcome to, if you want to learn a little bit more about this, feel free to use these links. All of these slides will be uploaded. But this collaborative model is a time-limited effort that brings together lots of teams from lots of different health services or sites, and they work together on a common aim. And ideally, that aim's about trying to close the gap between whatever's considered best practice and whatever is current practice in a particular topic. So this collaborative model is a structured approach, and all the teams come together and they attend learning sessions with both improvement experts and also experts in whatever the topic of focus is. And they learn about evidence-based change ideas and improvement science, particularly the model for improvement. And you can see the model for improvement is in the centre of the slide. And then they return back to their own organisations and they apply this knowledge during action periods where they use the model for improvement, and they go and they test change ideas and they make refinements where needed, and they try and embed the changes that are actually resulting in improvement into their daily practices. And then the teams themselves, they remain very connected throughout the action periods. They've got coaching calls, and they're also constantly sharing knowledge and resources on an online collaborative learning system. And they continue to collect and report data as they test change ideas. And then this data is shared between the teams to inform action so they can sustain improvements and spread impactful change ideas. So I know it's a little bit complicated, and I know this diagram's a little bit complicated, but that's a very quick overview of the improvement methods used. And again, if you want more information, just hit those links. And I think now is where the interesting part comes, is actually getting the panel to tell us a little bit more about how they applied improvement science in practice in each of their collaborative projects. So Barb, I'll hand over to you to tell us a little bit more about WHA's National Collaborative.
Thank you very much, Lisa, and I'd like to thank the IHI for inviting WHA to contribute to the panel today. I wanted to begin by acknowledging the partner organisations that we worked with, the clinical excellence agencies across Queensland, New South Wales and Victoria, who contributed time and expertise and made it possible for us to do a national collaborative. WHA is actually a national not-for-profit organisation with around 86% of public births taking place within member hospitals. As Lisa mentioned, there's about 140 maternity units. And that actually gives us the opportunity to help those services share a lot of clinical data around how their care is occurring. And several years ago, there were high levels of concern about rising rates of perineal tears occurring for women having vaginal deliveries. So we embarked upon a project to try and make a difference in that space. And of course, anyone who's had some understanding about third and fourth degree perineal tears would understand that it's a highly impactful event for many women. Some women experience lifelong harm associated with this outcome. And it's really important that we do better to A, try and prevent this harm, and secondly, to try and make sure that women have early identification and treatment if possible to minimise the impact on their lives. So we embarked in 2017 upon a national collaborative using the IHI Breakthrough Series model, and our ambition was to try and reduce by 20% the numbers of women that were actually experiencing a third or fourth degree perineal tear. We also had the dual objective of raising the awareness and building capability within our member services about how to use improvement science to make a difference on any of the problems that they were seeking to improve upon in their health service. There were 28 services that elected to participate in the National Collaborative, and these range from very large hospitals with 7,000 or more births per year through to some very small services with fewer than 200 births per year. And together they cared for about 60,000 or 70,000 women who had vaginal births in that period of time. We brought together an expert panel with obstetricians, urogynecologists, midwives and consumers, and reviewed the literature and designed an implementation bundle, a change package that we thought would be informed by the evidence and would make a difference to try and improving the experience of care for women. We also co-designed with the consumers themselves a information sheet, and this was a really crucial part of the project where, you know, how much information is too much, how much is not enough. And on a sensitive issue like this, we didn't want to frighten women, but we wanted them to be informed and be able to make clear decisions about their consent to receiving the elements of the bundle at the services they attended. So this was a really fabulous resource that was created by women and tested with 100 pregnant women to see if it met their need. And we embedded the consent of women through all stages of the project. Obviously, each woman's clinical circumstances was something she could discuss with her care providers, but by making information available so that there was discussion about this harm and its potential impacts and about what the bundle was seeking to do to prevent that, then women could make informed choices. And I was very privileged to have Dr. Deborah Browne as the collaborative director, and I'll hand over to Deborah to step you through what was achieved. Thanks, Deborah.
Many thanks, Barb, and to the IHI for giving me the opportunity to present these fantastic results. If we look at the statistical process chart, which fundamentally combines both the outcome and the compliance with the bundle, we can see that if we compare the implementation period with the pre-implementation period, that there was a decrease of 13.43% between the two periods, given that the mean dropped from 4.25 to 3.61. This was associated with an increase in compliance with the implementation of the bundle from 17% to 72%. This in fact translated into 473 fewer women experiencing a third and fourth degree tear during what in fact was a relatively short implementation period. In fact, it was only a year for us, as distinct from the normal 2+ years for a breakthrough series collaborative. There was very clear evidence from looking at our outcome data that in fact the improved compliance with the interventions of the bundle had really worked. In particular, if you look at the first spontaneous vaginal birthing group, there were 24% fewer women experienced a third and fourth degree tear when those women had an episiotomy performed for a forceps delivery, and 16% less for those that had it for a vacuum delivery. It was very interesting to understand how each of the teams learned how to redesign the local processes, albeit in some instances in very unusual ways, to drive that baseline compliance from 17% consistently up over the 40 weeks of the collaborative to 72%. If we look at two of the interventions in particular, there are some really interesting factors. We can see that the baseline compliance with the warm compress was remarkably low at the beginning. And this caused quite an interesting stir for our teams that participated, because their perception was in fact that they were very compliant in this area. This was very distinct to intervention 3, where they thought they were very compliant in cutting the episiotomy at the minimum angle of 60%, whereas in fact, when they came to measure it through the course of the collaborative, this was far less. When we compare the pre and post capability assessments of quality improvement knowledge and practical experience between the beginning and the end of the collaborative, this slide demonstrates a very significant increase both in their knowledge and in their practical experience, which was very satisfying given that this was the second aim of the WHA collaborative that Barb has already referred to. And I suppose the greatest joy we had was when Safer Care Victoria, our strategic partner for the WHA collaborative, engaged in their own collaborative, statewide collaborative. And given the immense passion and commitment of the 10 participating teams from Victoria in our WHA collaborative, I have absolutely no doubts that when we hear from Victoria, they will celebrate the phenomenal work that they have done. So with that, I'm going to hand over to Felicity. Thank you.
Thank you so much, Deborah. And what a tremendous photo. Imagine all of those people being in the same room at the same time now. It's quite startling to see in our current context. I think it's safe to say, all of the teams involved in Better Births for Women are immensely grateful for the groundwork that you laid with the National Collaborative, and it was tremendous to hear a little bit more about that today. And I'm going to step in now, and Rebecca Reid and myself will talk a little bit about these two maternity collaboratives, Safe for Baby and Better Births for Women. And just wanted to make a small acknowledgement there that for phase one of this work, we were joined by our IHI partners, Jenny Ross and Jane Taylor. Lisa talked a little bit before about, the crucial, those crucial elements of improvement being will, ideas and execution. And the will here, or the burning platform, was really powerful for both of these pieces of work. And the burning platform they shared was that we knew women and their families were experiencing harm in our system, and there were people out there deeply committed to reducing the rates of this harm. But the other thing, kind of fanning the flames of that burning platform, was there were great examples of how we could make things better, of how we could improve. So in the perineal trauma space, obviously the example set by the National Collaborative showing what was possible in introducing an evidence-based bundle of care. And then in the stillbirth space, there'd been work undertaken in the UK with the Saving Babies Lives care bundle, and also work closer to home with the Australian Stillbirth Centre of Research Excellence developing the Safer Baby bundle. So we had these great resources and this great passion for reducing harm for women and babies in the system. The specific aims of the work are on the screen there. So reducing the rate of stillbirth in the third trimester of pregnancy by 30%, and reducing the rate of third and fourth degree perineal tears by 50% in our participating services. And this map on the screen here shows you where in Victoria these services were. So all the little red dots are the Safer Baby services that were with us through phase one and phase two of the work, pre and post, a little bit of a pause for the pandemic, which Rebecca will tell you a bit more about. And the blue dots there are the Better Births for Women teams. And there was great variation in these services. Obviously in location, there's metropolitan Melbourne, city hospitals in there, and regional and rural services. There were services where there were 100 women giving birth every year, and services where thousands of women were giving birth every year. We had teams of 2 midwives working together. We had teams who had 20 working across 2 campuses with little subgroups, and all sorts of team membership happening there. There were obstetricians, GP obstetricians, improvement team members from their quality teams, and in many places consumers as part of these teams as well. And the other way these teams varied was in their experience using improvement science to learn from their systems and generate change. And really change is what we were looking for. We wanted to jolt people out of that same old pattern of thinking and get them out of getting the same old results. So we had to come up with a great theory of change. And as we pointed out, we had excellent examples set for us in terms of the clinical interventions that could lead to better outcomes. And then when we met with our initial working groups with many different stakeholders, clinicians, consumers, service leaders, system leaders, researchers, they built out that theory of change, or those ideas about what could lead to improvement. And both pieces of work really brought together the clinical interventions and this desire to partner with women really strongly in the design and delivery of this improvement work. And you can see, this slide will be familiar, the focus areas from the Better Births work, have those critical clinical interventions, but are also underpinned with that desire to partner with women during pregnancy and birth around designing the kind of information they would receive and around the decision making about those about that care provision during their birth and afterwards. And likewise with the Safer Baby work, a key and quite challenging element was around partnering with women to build shared decision making around timing of birth. So I'm going to hand over to Rebecca now, who will take you through some of the ways we measured and some of the outcomes. Thanks so much, Rebecca.
Thanks so much, Felicity, and it's lovely to be here. Thanks for having us. So really just to quickly step you through what our measurement approach was for these two pieces of work, and I think starting with the Better Births for Women, again, we had the foundational work that had been completed by WHA in relation to this, but when we took it to our expert working group, really the sounding voice that came out is what were the things that were going to speak to our clinicians in order to learn the actions that they were taking were making a difference. And we really wanted to make measurement about a learning story and a narrative of how we were going, as opposed to being this dry thing that they were used to perhaps looking at and putting on a shelf once and then not coming back to. So for our Better Births for Women collaborative, the key area of outcome that we were looking at was an overall TARES rate, but there was a real clinical interest in breaking that down to non-instrumental births and instrumental births. And that became really, at the beginning, there was debate about whether we needed to have that breakdown or not, but hopefully you'll hear by towards the end of our story the interventions that our clinicians were needing to do, their ability to pinpoint where they needed to target the craft groups that were working on this. It became essential that we had this breakdown as a part of our outcome. Safer Baby, again, we had two key outcome measures that we were looking at, and that was around the rate of stillbirths at 28 weeks or more gestation, but also the significant contributor to stillbirth around being smoking cessation. And you'll see as we step through our results why that was so important to maintaining motivation and will in our clinicians too, because of the outcomes that we've received or achieved rather. So there were a number of process measures that we looked at as well, and similarly to the WHA experience for our perineal tear work, we really wanted to target on those key clinical interventions we wanted to make reliable and consistent in our system. So you can see as you look through the list on the left there that the process measures really targeted the clinical interventions that the clinicians were wanting to carry out with every woman every time where clinically appropriate and indicated. And similarly for our Safer Baby collaborative as well. So we had a range of process measures that predominantly focused on the clinical interventions, again, focusing on that notion of reliability and consistency in care, and that every woman, every time they came into our service, knew and could expect they were receiving the best care they possibly could. I think that notion of reliability and consistency is really something useful to take away and lean on. It actually helps draw the heart to why I'm here as a clinician as well. And I'm a bit passionate that measurement strategies are not just these numbers, that they are actually this narrative that builds heart and connection to the work and what we're doing. And so finally, our balancing measures. Again, this was a really interesting process to step through with a group of clinicians around what is it upstream, downstream, side stream that they wanted to keep an eye on that would say, what are these interventions actually doing outside of where we think they're going to impact. And so for our Better Births for Women's piece of work, we were looking at episiotomy rate and caesarean section. So sort of really starting to think about that concept of risk and what was our thinking in regards to risk, and was it actually unintendedly making some unintended consequences, I suppose, in regards to decision making and clinical practice. And similarly for Safer Baby, we really wanted to look at decision making around induction of labour, and then also connected to that the number of babies who may have been admitted to special care nursery after 37 weeks. So Felicity mentioned this pause that we had, and I think it's really, when we start to look at our results, I think you'll see in our data reflects this sort of pattern that is maybe perhaps slightly unusual, but when I explain this following bit may make more sense. So our maternity collaboratives in Victoria had an unprecedented amount of interruptions, from cybersecurity attacks to bushfires to floods to then the COVID-19 pandemic, all of which our clinicians and teams across both of these collaboratives really worked hard to stay connected to the work and continue to strive for that excellence in care and consistency of care of every woman every time they came into contact. But unfortunately, COVID got the better of all of us, and there was a need to actually sort of pause and take the pressure off people. And so we continued to work across that program. So we really paused phase one, had a break. Some teams continued slightly in the background, and then other teams needed to pause completely. And then we resumed in phase two. And so what did our results look like? So for our Better Births for Women's collaborative, we achieved an overall reduction of 45% in our perineal tears, which for our population of women that we were serving equated to 155 women who potentially avoided a perineal tear. And you can see on the slide that across all of our process measures, you can see that there's been an increase an increase in reliability and consistency of the key clinical interventions. And for our Safer Baby collaborative, our results were that we increased the average number of days between stillbirths from 3.5 days pre-collaborative initiation to 8.1 days, which is just an astounding outcome and result. We know that when we look at the pre-collaborative phase to the active collaborative phase, that we were just on the verge of a shift and seeing some movement, but we know the interventions that people were doing were starting to positively interrupt the system. When we look at pre and post collaborative periods and active periods, we saw a 21% reduction in the number of avoidable stillbirths, which is, again, I don't know about you, but that gives me goosebumps. It's amazing. And again, I'll just quickly pass over. You'll see these in our slide deck, just the relative process measures that we were measuring as well.
Amazing work. Thanks so much, Beck, Felicity, Barb and Deborah, and I also have the sense of the goosebumps. And really it's just so clear what an impact this work has had on the lives of women and their families. I think, like many of us who are listening, are really wanting to dig a little deeper to try and understand how you were able to achieve these results, including with everything else that was going on at the same time, and what you thought were some of the essential elements or the kind of pearls that you learnt along the way. And I was thinking back to a conference that I went to where Don Berwick was speaking, and someone was asking him, does quality improvement actually work? And his answer was sometimes. And it's kind of spot on, because we know that sometimes our improvement efforts have results that exceed our expectations, so sort of like what we've seen today. But there's also other times where we've got projects and they limp along and they never quite kind of get traction and they don't really have any impact or very little impact. And so what we'd really like to know from you is what you see were the elements that you would say made the kind of greatest difference, and the things that you would say were the kind of must-haves that have helped you get these results, despite the kind of setbacks that you had and the challenges, or, Beck, as you just talked about, the kind of unprecedented interruptions, like the pandemic is something that, let's hope that we don't have more of those sorts of things, but we know that at the moment it's just so very real and top of mind for so many of us. So maybe, Felicity, we'll start with you. So having hindsight's pretty wonderful, but reflecting on all that you know now, what advice would you give others as they embark on a kind of QI journey similar to what you've done, and how would you say they should set themselves up for success?
Thanks, Lisa. And as you'll see on the slide here, number one is be prepared. And, we might be doing improvement work here, but really what this amounts to is having some fantastic, almost fanatical project management thinking and skills and experience in this space. You know, you're taking people on a journey, and sometimes a really long journey of a couple of years, a lot of people, a lot of moving parts. The more you plan ahead, the safer and more effective and more enjoyable that journey is going to be, just like any journey you might be planning. And so be really rigorous about that. You know, people can engage more effectively and more, more enjoyably with you if you give them as much information as possible ahead of time. So give them as many dates as you can, as early as possible, so they can start to organise their calendars. Be really clear about what it means to show up to the things that you're inviting them to and the kind of preparation that they should be undertaking, and where you can, show them examples of what good looks like. You know, what does it mean to come and present as a team at a workshop where they're sharing their work? And then you can be fanatical about your plans, but you can't be rigid about holding on to them. Just hold them ever so loosely, because everything can change. So you need to know where you're going, and then you need to be really open to getting there in lots of different ways. And that can be on a really small scale. You might be running a coaching session with a group of teams, and you've got some questions that you want to use to shape that coaching session, and they show up and they're in a very different space and you need to change gears. Or it might be on the very large scale, where the whole time frame and structure of your work has to be re-examined and reshaped to meet people where they're at in the complex system they're in. So that is in a nutshell. Prepare rigorously, hold it loosely.
Excellent. I love that saying. But what was really clear is, as you've all been presenting, is the really important role that women, plus the clinicians who provided care to those women, played in both co-designing but also delivering the improvements. Deborah, based on your experiences, can you tell us how you actively involved women and clinicians throughout, and why did you find this so important?
Thank you, Lisa. I think first and foremost, one of the most fundamental principles of both collaboratives is to ensure that we are able to design our systems to deliver highly reliable, sustainable care to every woman every time. And so it was very clear from the outset that we needed to engage women and we needed to engage the clinicians in the design of the entirety. And so, in fact, the expert panel had a membership which incorporated 4 women, midwives and obstetricians, in order to hear their voice in the design of the entire collaborative. And I would start really that the contribution of the women, particularly at the expert panel, actually helped inform the content of the perineal protection bundle. It became incredibly interesting to hear their voices, particularly around intervention 4, which was going to require them to permit a rectal examination on their intact perineum, potentially every time. And that was quite a challenging area of evidence that was being proposed. But the voice of the women, interestingly, on that day was the loudest in the room. And really, it was included into the bundle because they felt very, very strongly that they would want to know if they had had a rectal buttonhole tear that was previously undiagnosed. Similarly, they were involved, as Barbara's already alluded to, with the patient care leaflet. They designed that for women by women, and it was tested using quality improvement methodology across many of the 28 hospitals that participated in the collaborative. And in fact, it's now been translated to at least 8 languages, as I understand. The women were also involved in the final how-to guide, so that we were able to create a narrative that was sympathetic for them, as well as the healthcare professionals that were tasked with the challenge of actually reliably delivering every component of the bundle every time, where appropriate and consent was given. And so we felt that we had captured the voice of the women because they were very included in all components of our work. But equally, it was very important that we were able to capture the voice of the clinicians, both the midwives and the obstetricians, in the design of the perineal protection bundle, because we were more than aware that we came from the expert panel with a list of interventions, but fundamentally, in order for these clinicians to deliver this 24/7, 7 days a week, in the most remote environments to the most sophisticated environments, we needed to understand and sense check both the knowledge within this bundle and to make sure that it was not used as a retrospective audit tool, but that in fact was used as a reliability tool. And many teams came to incorporate it within their birthing packs. Many teams came to incorporate it into their desktops to ensure that they were able to do the right thing every time. The measurement component of the bundle proved to be incredibly helpful. And it did so because it allowed the teams to target where, if they had been successful, for example, in applying a warm compress, they may not have been as successful in doing an episiotomy at the right angle. So it was a very informative tool. Fundamentally, this tool was tested using quality improvement methodology across multiple sites, and I was very pleased 8 weeks later to be able to present the final tool to the first learning set that took place in early November, which in fact immediately prior to the learning set was reviewed by a human factors expert. Interestingly, they highly commended it, and I always felt that was a great testament to engaging with clinicians in designing these things is always the most prudent thing to do. I think probably my final comment here on the design by the clinicians was that it was critically important that whenever a bundle was used on a woman, if in fact that woman had gone on to sustain a 3rd degree tear or a 4th degree tear, it became very important that they use this as a reflective tool, but importantly to also understand that they had done everything they could and that potentially that harm event was in fact potentially unavoidable. So I hope that helps you understand the passion with which we designed the tool for both with working with women and our clinicians.
Absolutely, that's very, very clear. And building on that sort of element of co-design and working with both the women and the clinicians, it really does seem, and it's a thread throughout all of this work, that the relationships and connections were really core to the success. Felicity, I'm interested in understanding more about what you did to establish and then try and sort of really strengthen these connections that were, you know, part of every single one of these stories.
Thanks, Lisa. And I think someone used the word affection recently in describing, you know, what it takes to really achieve this large-scale improvement, and affection as being really core to it. And that really speaks to me and what was going through my mind when I was thinking about this particular tip. And, you know, this is critical, and we saw this all through the work in every relationship, whether it was between our team and the hospitals, within the hospitals, between the teams and their sponsors, between teams and consumers, every relationship you could think of, when there was warmth and trust and a little bit of humour and openness and willingness to connect with one another, the work was better and stronger and more enjoyable. And I keep saying enjoyable, but it's actually really important that you like what you're doing in this space and that you want to keep showing up every day, because it's a big, challenging thing to pull off large-scale improvement. So you want to look forward to it. So, you know, as these points on the screen say, really dedicate the time to the relationships, and particularly in the early stages of the work, set aside time to phone people and connect with them and build that warmth and trust. you're working in a complex space and you're not undertaking a straightforward technical challenge. This is an adaptive challenge. We might have known evidence-based interventions, but the solution for making those a consistent and reliable practice is not known in every space. And creating that knowledge and learning from the system requires everyone to come together, and it requires that trust to be able to speak up and share ideas and hear other people's ideas, and the bravery to give things a go. So you really want to be able to lean into those relationships as as the work unfolds. And a key part of that is, remember to pause every so often and celebrate even the just little things, to pick up the phone and say, wow, I saw your process measures for this particular part really jumped and you must have done something great. Let's talk about it. Or on the large scale, when you're meeting with all of your teams together, if you're doing a big collaborative piece, acknowledging how far they've come. It really, you can see how it really boosts people. So a few other more specific tips. Sorry, I'm going back. Keeping in control, I just wanted to give a couple of other specific tips there. If you're an individual and you're working in improvement, be curious. Be curious and seek out those connections. If you're a team, know what it takes to have great improvement, experience and skill in the team and what leads to effective work. If you're a sponsor of improvement work, do what our sponsor says and be the Drano. Find out what helps the team move their work forward or what holds them back, and help them out. Unblock those blockages and help them keep moving. And if you're a system leader, be the switchboard. And that's what I was a lot of the time. Really, like these ladies, just connecting people by email, by phone. And so hopefully that'll give you a few ideas to move your work forward, whatever scale you might be working at.
That's a heap of ideas. I do like the switchboard and the Drano analogy particularly. And you talk about celebrating the work, and I think many people have heard the results would be feeling a sense of, wow, these are impressive. And I think there's a small temptation for any one of us to want the kind of quick fix or the guideline that kind of gives us those instant results. Beck, I'm interested if you could tell us a little bit more about what's so special about context when it comes to achieving improvements.
Thanks, Lisa. For me, context is everything, probably for a couple of reasons. There's two things that I think happen when we start thinking about context. And I think that is a lot of people, particularly our system leaders, automatically go to context thinking about that at a system or an organisational level. And I think they actually start distributing context to, do we have will? Is there opportunity in our health service? And almost frame context there. And then sometimes we don't start to think about it in any other way, shape or form. And I'm in no way, shape or form saying that's not important. That is the first context. Where do we start? That is the first level of context we need to understand. But the context that I'm passionate about here is actually helping people recognise that the complete and utter intent and purpose of doing improvement is to make a difference at the floor level for the people who are coming in and receiving the care that we get. And I think one of the things that we lose, particularly as people who, what I say, have the sight or may perhaps preach from the altar of improvement and love it, and forget that we're working perhaps sometimes with people who don't necessarily have that same understanding, is actually bridging that translation gap of what does it mean? What does it actually mean when we're doing improvement? We know as improvers that we're taking ideas that we hold a high degree of belief and confidence in, these evidence-based ideas that we know if we use them reliably and consistently every single time, they'll make a difference. When we're working with people who are not so experienced in improvement, which is often most of our clinicians, they often get confused with research and improvement. And so what gets lost in translation is actually we're taking this idea and we're testing it in a whole range of contexts and situations. We want to understand what are the structures and the processes and norms that sit around making this change idea acceptable, effective and efficient every single time for every single person. What we're not doing is saying and proving that that change idea actually has efficacy and reliability. So we're not testing to prove the idea is researched and evidence-based. We know that. That's why we're using it. That's why we've selected it and aligned it to achieving our outcome that we're working towards. what we're really wanting to understand is what are the contexts in which we need to use this idea? What do we need to learn? What do we need to understand in order to make it effective every single time? So if I come back to it, context is absolutely everything. It should change, and we should be deliberately thinking about how we're learning and growing our understanding of context to make sure that that change idea can happen. And that probably sums it up in a nutshell, I would say.
It certainly does, and it kind of is a good segue into thinking about how you actually execute or deliver on improvements. And Deborah, I was wondering whether you had any advice for others who are planning to use improvement science and keeping in mind Beck's point about context, but what you would say is important when you're thinking about trying to deliver sustainable results.
Yeah, well, thank you, Lisa. I think that I've probably got about 3 or 4 tips really, and I think I would always go back to the basics really, which is that I always loved Deming's quotation about without ideas, you're just another person with an opinion. And I'm very sure we've all been in the room with a lot of opinions and also people that don't believe the data that's presented to them. And so I think first and foremost, the hallmark of really good, successful work comes with your own teams and the work generating and collecting their own baseline data. And this was certainly pivotal for us in our collaborative. And I've just put a graph on the slide there just to demonstrate that when we started at the first learning set, everybody believed that they were compliant with delivering evidence-based medicine and best practice guidelines because they went to work every day and tried to do the right thing. But fundamentally, when they collected the compliance against the delivery of the bundle, they came to realize that across the entire bundle, that they actually were not able to achieve it because their system was not designed to help them do it. And so first and foremost, I believe that baseline data is immensely helpful because for us, the narrative in the room changed instantly. It defined the burning platform, and they had lit the fire themselves by bringing the data to it. I think the use of the Pareto tool, I gave it a little special place here because I believe as an experienced improver that this tool really allowed, and particularly in relation to work on bundles, allowed our teams to really understand where the deficit was. And again, it highlighted something I alluded to earlier on, that this slide represents those group of women in our baseline group, of which there were 1,334. We had in fact used the bundle on 19,000 women, but this was our baseline data. And they came to understand very early on that 300 of the 7 women out of 700, in fact, had not had a warm compress placed where they thought they would have. And so equally, they thought that they were doing the episiotomy in the right way at the right time. And it came as a great shock to them to discover that that wasn't the case. So baseline data, if at all possible, would be my first top tip. My second really would be that in order to achieve reliable, sustainable care, we do need to encourage all people involved in doing translational medicine work and using the PDSA as that tool to be pretty religious about some really, really simple things. One is to understand that the tool itself is there to test a hypothesis, for you to be big and bold, and for you to check your predictability, but also to document, because it's far better to fail quickly and move on than it is to spend a lot of time failing very slowly. There's nothing more demoralizing in improvement work than being a lone ranger trying to do all of these things and or not sustaining care. And we're all very, very familiar with that as an outcome of a lot of improvement work. And so my pledge here to you and my advice here to you is to make sure that you drive the reliability of each of the components by using your PDSAs wisely, by documenting it, being disciplined, and making sure that there's measurement associated with it. And as this graph demonstrates, we were actually very religious about making sure that the teams would get to reliability for each of those 5 interventions. Remember, they had to get to 95% reliability with each of the interventions in order to make sure they were going to reliably deliver that bundle for the women every time. And only after they had achieved the kind of classic 6 points consistently did we then move into that classic Duran quality assurance space where they were starting to audit on a more regular basis to be able to demonstrate that they had been able to sustain that reliable, sustained improvement. So being very, very conscientious and diligent about how you work together as a team. And my final comment about this approach is, particularly in bundle work, this material, this work can be done simultaneously and not sequentially, and that had to be done in that way. So we would have some core teams working on warm compresses, which were classically the midwives, and much of the episiotomy work was obviously done by obstetricians. My kind of final comment here, and this is my passion, I guess, is to teach and understand that your system, your microsystem that you work in, is perfectly designed to deliver the results that you get, the outcomes that we can achieve by the best practice. And so we are probably the very best people to redesign the processes in the systems in which we work to enable us to deliver evidence-based practice to the very best of our ability and do what we get out of bed every day to do, which is to take care of our women in the best way we can.
Very good reminder. Every system's perfectly designed to get the results it gets. Thank you. Now, one of the kind of last bit that we would like to talk about is around communication, and I'm going to ask this question to you, Barb, just around the essentialness of communication and the fact that it really can make or break improvement efforts. I'm wondering if you could share some of your takeaways. Like, what did you think was critical to be able to be effective in the way that you were communicating throughout this work?
Sure. Thank you so much, Lisa. Look, as my wonderful panel colleagues have articulated, there's a whole stack of communication that goes on as part of a large-scale collaborative improvement effort. And you're talking to the teams, you're talking to the executive sponsors, you're talking to system leaders and partner organisations, and it feels, all-consuming and robust. But I think the one thing that I would share that I learned from our experience was that the former President of the United States has made very clear to us all how powerful social media can be in the spreading of misinformation in the globe on all sorts of topics. And the same is true actually within the collaborative improvement space. And we learned that lesson the hard way, actually. We found that partway through our efforts, some of our participating teams started to experience agitation and noise, I guess, in social media on their Facebook pages and coming through in a range of feeds where women were expressing anxiety and concern based on ideas that were not factual and not related to what we were actually doing. And I think the most offensive of those for me was an allegation that was made and articulated in social media that WHA as an organisation was recommending women be raped after their births because we were stressing that women should be offered the rectal examination that Deborah was talking about. So after much agonising about that process, we followed in the footsteps of a Nobel laureate in deciding that we're actually not going to engage directly in that space in trying to counter some of the claims that were being made, because we thought that was likely to be not a productive use of time and not necessarily reaching the audiences we wanted to reach. So we sat back and had a really good think about our communication strategy. And at about that time, the hashtag QIComms resources were published globally. And I would highly commend this framework to people. It really enables you to rethink and step through in a very methodical way who it is that you're engaging with, the kind of messaging that you're doing, what avenues, what channels that you might use to communicate about the work that you have, and to essentially tell the story of the improvement effort that you're making. There's such goodwill and such momentum and effort in these collaborative projects, but of course there is also a wider audience who are not part of the collaborative work, the clinicians and consumers and the general public, who weren't initially in our sights for communicating proactively about what we were doing and why it mattered and why we were trying to make a difference. So we ultimately combined some of the data, some of the stories from women into some various visual tools that enabled us to become proactive in communicating positive messaging around the improvement effort that was being made. And that ranged from a range of tools where we actually articulated what the myths were that were circulating and our counter to them and circulated those widely. We created videos, like 10-second or 5-second videos that we put out on social media channels to articulate the benefits of what we were trying to achieve to unknown audiences. These weren't necessarily people that we would have expected to communicate with. So I think if I can share a painful learning from, with the benefits of hindsight, I would encourage everybody to be proactive in thinking about the communication around your improvement work to a much wider audience than you might imagine.
And I think sometimes those painful learnings are some of the best kind of learnings that stick with you for a lifetime. So really, thank you so much, Barb, and actually a huge thanks to the entire panel, Deborah, Beck, Felicity, for really sharing your knowledge and your expertise with such candour and including stories like you've just told, Barb, so incredibly helpful for people kind of about to do similar work. And I think, in terms of this discussion, it really has, for me, highlighted both the art and also the kind of science of improvement. And I think it's been really well stated by all of you that it's not just about really rigorously following a methodology like sort of Beck was talking about, but it also requires a really strong preparation, but an ability to adapt. I mean, pandemics and IT outages and all of those things that you talked about. I think it was Felicity, you were talking about Safer Cares, what occurred through your collaboratives, and being able to make those adjustments to the local context, which clearly was also really important. And the other piece for me is the kind of art and science bit around co-design and co-designing with your consumers and co-designing with clinicians, and how do you actually really nurture and cultivate the connections and relationships. And as Barbara's just said, that kind of constant communication and being able to evolve that communication for whatever is needed for that point in time throughout an improvement effort. So, I mean, Felicity, you talked about complexity, absolute complexity, but I think the piece here also is the kind of doing it with others. And I think when I think of that saying, if you want to go fast, go alone, but if you want to go far, go together. And it seems so true for this improvement work that we're so much likely to have a bigger impact and much more likely to be successful when we're working together, which you've all talked about, that element of working with clinicians and consumers and the participating teams. So huge thank you. And we just wanted to say that if you wanted to learn more and kind of keep trying to master the art and the science of improvement, please visit the IHI website. There's heaps of resources and materials and courses that you can download. We've also got the IHI Open School, so there's lots available to you. But we are so grateful for your time, and we would love for you to join us for an informal discussion with the panel. I know we've covered a lot in the last hour, so we really want to know what is actually still circling for you. Like, what are things that you still want to explore further? We'd love you just to type your questions or your comments into the chat. We also acknowledge there's a huge amount of expertise in the room. We know many of you are either leading or you're very involved in improvement work. And so we'd love to learn about what you're doing and hear from you, whether you've got other essential elements that you'd add or things that you might want to change to what you've heard today. What are you thinking is really core to the success of your improvement work? So thanks so much, and keep typing those comments and questions into the chat, and let's go and answer them. Thanks.